It's my pleasure to next introduce our next speaker, Dr. David Affleck. Dr. Affleck was raised in Utah. His parents graduated from Ogden and Weber High Schools. He attended the University of Utah from 1989 to 1992, and he received a bachelor's degree in human biology and had a minor in Spanish. He attended the University of Utah Medical School as well as surgical residency, also at the University of Utah. He did a cardiac surgical fellowship at Washington University in St. Louis, and it was there where the Maze operation was invented by Dr. James Cox. He joined Mountain Star Cardiovascular Surgery in 2004 with an emphasis in cardiac arrhythmia surgery. He has performed over 170 minimally invasive Maze operations at Ogden Regional Hospital and at St. Mark's Hospitals. He currently practices, or his current practice includes coronary bypass surgery, valvular repair, Maze, both open and minimally invasive, as well as non-cardiac thoracic surgery for malignancy. He's certified in a variety of other things, and he served as a national proctor for the mini-Maze teaching, and has proctored more than 20 surgeons across the United States in minimally invasive techniques in cardiovascular surgery. We're pleased to hear from him. He's going to discuss minimally invasive atrial fibrillation ablation. So, Dr. Maze, or Dr. Affleck.
Good morning. Well, I'd like to thank the Society for the privilege of presenting to you today. I've never been to this conference. This is a bigger group than I'd expected. I want to try to convey to you today my enthusiasm for the surgical treatment of atrial fibrillation, and really what it gets to is the cure of atrial fibrillation. I want to give you a brief overview. First of all, talk about the scope of the problem. Many of you, of course, deal with atrial fibrillation, but I want to break it down briefly into the categories, the classifications, and then go through the surgical history, how the surgery for atrial fibrillation has developed and how it has evolved into some minimally invasive approaches. I want to review the recent peer-reviewed literature in minimally invasive surgery and discuss the outcomes that are published, and then give you some exciting new horizons. So the scope of the problem, some of you may look at this slide and go, wait a minute, that seems a little bit high. It is staggering, the number of patients in our country, the number of people that live with atrial fibrillation. Of course, I'll go on to a few of the next slides and explain this in more detail, but certainly there are somewhere between 15 and 20 million Americans with a five-fold increased risk of stroke. Afib is responsible for 15 to 20% of all strokes. And then along with living with atrial fibrillation, you have, of course, all kinds of other problems, cardiomyopathies associated with long-standing tachycardia, atrial fibrosis, and everyone in this room is very familiar with side effects of the medications that are used to treat atrial fibrillation, as well as bleeding complications. So this is a really interesting study that everybody that does arrhythmia surgery has pointed out over the years, and of course this was published in JAMA in 2001. And if you look at this slide, it's kind of interesting because if you put it in 2010, you say, oh yeah, there's about, supposed to be somewhere between 2 and 3 million people with atrial fibrillation. More recent population studies have suggested the number, this suggested we were going to reach 5.6 million by the year 2050. We're certainly somewhere between 15 and 20 million. It is a much bigger problem than we thought previously. So I always show this slide, or I'm not sure, I don't show this slide, but I draw this diagram for my patients when they come in for a consultation, no matter whether they've arrived as a self-referral or from an electrophysiologist or a cardiologist. There's a study called the Affirm Trial, and we could argue about, exactly the pros and cons of the trial, but what's interesting about this is that on this axis, they have major events, bleeding, stroke, and death. So major complications. And they took two groups of patients and they managed them for rhythm control and rate control, maximal therapy, and they followed them over time. And as you can see on this graph, which stops at 5 years, it's essentially a slope that goes straight up with a complication rate that approaches 30% at 5 years. And I use this not as kind of the absolute law, but if you think about it, who of us would propose to a patient a treatment over time or a surgery, if you're a surgeon, and say, we're going to have 30% complication rate over 5 years, here, sign this consent? It's crazy. It's just crazy. So I want to break it down and talk to you about the classifications of atrial fibrillation, how that relates to my treatment. Paroxysmal atrial fibrillation is atrial fibrillation that comes and goes. It's self-limited. It starts and stops on its own. If you get into the persistent category, this is long-standing. It does not start and stop on its own. It has to. The patient is cardioverted, either chemically or electrically, and having that conversion to sinus rhythm does not change their category. Once that's done, they are a persistent Afib patient, and of course permanent, or what everyone kind of knows as chronic. It's important because the longer patients have atrial fibrillation, the more difficult it is to cure by any means. In other words, living with it, I feel good, I'll take my pills, I'll go get my INR. Living with it, it just leads to more prolonged problems that are then less treatable. So early intervention is important. So the two classifications that I primarily focus on in terms of minimally invasive approaches and some of the new ideas that I want to talk to you about are paroxysmal and persistent. In this permanent or chronic category, this is primarily treated and best treated for cure with a open maze procedure, which I'll explain to you. So this is Barnes Jewish Hospital, or WashU in St. Louis, where I did my fellowship, and I used to sit across the little pond there in Forest Park when I was stuck on call and could get out of the hospital for just a minute and sort of lament why I'd been there for 3 straight days. But this is where James Cox developed the maze operation. It's one of the only, if not the only operation in all of surgery, including all types of surgery, that has gone from basic science to small animals to humans, and then back to the benchtop, back to animals, back to humans, to evolve into an operation that could treat patients. Many operations they seem like they'd work, surgeons start doing them, they work, and there you go. And then there are retrospective reviews. This is one of the only operations, and this is where I did my fellowship. The idea is to make a maze of the heart, to create an electrical pathway where electricity starts and goes from the sinus node to the AV node and then to the ventricles. And, so it sounds pretty simple, but of course it's a 3-dimensional target. So the sinus node is here, and the idea is to create blocks where these atrial fibrillation signals cannot circle around and create reentrant circuits causing atrial fibrillation, both around the pulmonary veins, right and left heart, arriving to the AV node and then causing a synchronized heartbeat. Well, the open maze, here it is. This is how it was. This is what we did 3 or 4 times a week during my fellowship, which is classically known as the cut and sew maze. So this would be something called the Coxamaze 3. Okay, it was Coxamaze, Coxamaze 2, Coxamaze 3. The final kind of surgical iteration involving cutting and sewing. And this is a picture of the heart. Let's see, let me go back. So this is the right heart with cannulas in the IVC and the SVC. And of course, you open up the right heart with a series of cuts on the right atrial appendage from the SVC to the IVC. Then you have to cut the tissue down to the tricuspid annulus because there are many recurrent circuits that happen there. In the left side of the heart, you open up the left atrium, cut out the pulmonary veins as a tongue, and then sew them back together. Tease all the tissue off of the coronary sinus, which is the vein on the back of the heart, and then when you're all done, sew it all back up. A very big operation, a long time on the bypass machine, fraught with complications and not reproducible unless it's being done frequently. Therefore, it doesn't gain traction in many centers. So this is kind of what the final picture looks like. A lot of suture lines, a lot of potential sites for bleeding after a long bypass run. But the good news is, with the Coxamaze operation, it has stood the test of time. And if this slide demonstrates the stroke risk with varying different risk factors and treatments, and if you look at, of course, the top line is atrial fibrillation with risk factors, previous thromboembolic events, and no anticoagulation. Again, probably, we hopefully don't have patients like that. Hopefully, risk factors, these patients are being treated. But if you compare the stroke risk in each of these categories to a long-term follow-up of patients that have had the Coxamaze surgery, the stroke risk is extremely low over now decades with the Coxamaze operation. Very reproducible, good results in multiple centers all across the country, but again, a big operation. Well, as technology caught up to our desire to do this operation, we came to the Coxamaze 4, which is primarily the operation that I did as a fellow and that I do now for chronic atrial fibrillation patients. The Coxamaze 4, which is a combination of cutting and using cryotherapy and bipolar therapy. And what this does is, you can see the pictures are somewhat similar. There's cuts, they're slightly smaller, but instead of kind of cutting everything, you're using a radio frequency clamp to make burns that eventually become scar, just as the suture line would. It obviously speeds up the operation because not only you don't have to cut it, you don't have to sew it. The burn takes somewhere between 7 and 10 seconds. So the operation is much quicker, and therefore the patients do a lot better. And you accomplish all the same thing. Instead of cutting out those pulmonary veins that sit on the back of the heart, I mean, that's what that's tiger country. That's a terrible place to be if you have complications. And now it can be accomplished with a bipolar clamp. And of course, cut off the left atrial appendage in all patients in order to get rid of or diminish, if not get rid of, the stroke risk. We use cryo rather than cutting down onto the valve fibrous skeleton and burn the tissue there with cryo. Same thing we do that as well in the left heart. And then here's what you can see, the burns on those pulmonary veins instead of cutting them out. So as surgeons, we said, well, okay, we're already doing open heart surgery for other reasons. What if we have a patient that's having a valve replacement or repair or a CABG and they have atrial fibrillation? We're already there. Maybe we could, do these clamps now that we're there. And the idea for that really came from the electrophysiologists that have learned that in paroxysmal and in many cases of the persistent category, the signals for atrial fibrillation come from right around the pulmonary veins. Yeah, there's a few that are scattered on the right side of the heart, but the vast majority come right around some little muscular bands that are on where the pulmonary veins enter the left atrium. Well, that looks good. So let's do that for that category of patients and see what happens. So here's an open chest case for some other reason, sternotomy, place the clamp across the pulmonary veins, and lo and behold, it cured atrial fibrillation in those early category patients. And then on the left side of the heart, we would do the same thing. And then the next step was, well, what about a patient who doesn't need a sternotomy, who has lone Afib, but doesn't need a valve replacement, doesn't need a CABG, but, we're not going to follow that Affirm curve up to 30% over time. We're going to treat them. So we came up with sort of mini incisions, opening the pericardium and doing the same thing. Again, a progression to less and less invasive approach. And then on the left-hand side, doing the same thing and using a stapler, a mechanical stapler, to remove the left atrial appendage. So the idea there is to cure the Afib, get rid of the potential source for stroke, which is the singular reason patients with Afib are on Coumadin. So the next step was becoming even less invasive and trying to do more complete ablation. And one of the things that I do now in the operation is there are a series of nerves called they're ganglionic plexi that sit both on the right and left heart just in front of the pulmonary veins that can sometimes become rogue nerves that stimulate the heart and cause a reentrant circuit. And we're able to, through a minimally invasive approach, we're able to test all of those and burn them with a bipolar pen at the same time. And then, of course, this is the ligament of Marshall. There's a little tract that comes from the pulmonary artery on the left side down onto the coronary sinus. It's where the left-sided SVC was in utero, and in 99% of patients, that becomes this fibrous band that carries some nerve bundles. So the idea is to take that down as well to prevent those circuits, and that's one of the places the electrophysiologists really work at, trying to get the signals taken care of. So we take that down as well, and this is what it looks like on the heart when I'm testing the ganglionic plexi. Here are the pulmonary veins going out. Here's the lung on this side. Here's the heart on this side, and using this bipolar pen with the camera down below to test those nerves. And what it looks like is this. We stimulate the heart at 1,000 beats per minute on those nerves, and if those nerves are irritants to the heart, then you'll see on the arterial tracing, you'll see this beat and then all of a sudden a vagal response, only because the vagal response happens quicker than the sympathetic response. And so when we know that's positive, we stop, step on a pedal, burn the nerve, and then retest it. So it's quite effective and quite precise. And this is kind of what we end up doing through minimally invasive ports, some with a camera, bringing the instruments in through here, and then a small working port in each armpit. And let's see, there we go. So one of the great advances in technology has finally caught up with this. This is a clamp developed by Atroclip, which is a company that does only atrial fibrillation. And this light is so bright. Actually, when you start the battery, it's of course disposable, as medical companies want, so they can make more money. But the light will stay on for like 2 weeks. You can take it camping after. But it makes this procedure so much safer because through small ports, I can put those in back behind the heart, and using this bright light, I can rotate them behind the pulmonary veins, and with smaller and smaller incisions, bring a guide to allow me to get my clamp around those pulmonary veins. And that's what's shown here. It has kind of a condom, if you will, on the tip of that, and then the clamp is attached to that plastic tip, and I'm able to bring the clamp in there, place it right where I want it visually so that I don't stenose the pulmonary veins, place it down, and then there's a computer algorithm that measures the impedance of the tissue, just a short period of time. And once the lesion is transmural, then take the clamp off, and we're left with a circumferential burn that impedes electricity from those little fronds of tissue that, of course, are sitting right here. Now they can no longer pass into the heart and cause atrial fibrillation. So this is a picture, a real picture from the OR of the ligament of Marshall, and you can see here's the left atrial appendage. Not quite, it's kind of more confusing, right, than the cartoon diagrams, but here's the left atrial appendage, ligament of Marshall, and this is the pulmonary artery here, and the pulmonary veins coming over here. This is I've had many patients that while I take that down, the patient on the monitor converts from atrial fibrillation to sinus rhythm. Not with my ablations, not with cardioversion, but as I actually take down the ligament of Marshall, the patient just converts to sinus rhythm. So it's really interesting. This is what it looks like, again, bringing that clamp around in real time. One of the other great developments has been it's called a cool rail. And the reason it's called cool rail is it's a bipolar ablation clamp that I can use behind the heart that has a cooling jacket on the back of it so that it doesn't injure anything else around it. And any of you that know about atrial fibrillation ablation, either by whatever means, by a catheter, one of the dangers is, of course, that energy traveling out and injuring something else, stenosing the pulmonary veins, injuring the esophagus, other structures. This cooling jacket allows me to place it behind the heart and do more ablations on the heart without the danger of injuring other things. And this is, this is just briefly how it works. Again, the same computer algorithm, but instead of shooting the power out, it's a bipolar that goes between the electrodes. And this is what I'm able to do in a cartoon fashion once I'm all done. So I'm able to use the clamp to do pulmonary vein isolation on both sides. I'm able to use a pen to complete that up to the left atrial appendage, and then cool rails behind the heart to connect the right to the left side. This is kind of a posterior view, if you will. If you look from behind the heart, this is the aortic valve. And I'm able to create a box both above and below the pulmonary veins to isolate the left atrial. Again, much more complete ablation of more atrial tissue and the cause of atrial fibrillation than we could before. And one of the even more exciting, newer developments is the Atroclip. So for more than 150 of these cases that I've done, the left atrial appendage is removed with a mechanical stapler. The left atrial appendage is not a hardy structure. It is sometimes soft. They come in all shapes and sizes, short, fat, skinny, just like people. And stapling that, any of you that have used a mechanical stapler, you know, kind of when you push that stapler down, you're sort of committed to where you're going to, it somewhat crushes the tissue. Well, imagine doing that on a beating heart in a minimally invasive setting, and that has been, sort of, you do the whole operation, then you get to that and you stop and say, okay, I hope this goes well. Well, the Atroclip is a real exciting development because this has just revolutionized this operation, making it so much safer for patients. It's a clip that has some nitinol inside of it and some titanium that basically is, I tell people it's like a women's hair barrette. And it allows me to place that on the left atrial appendage, clamp it down under echo, make sure the left atrial appendage is gone. If I'm not happy with it, I can open it up, scoot it in more. I can move it around. It doesn't crush the tissue. It actually compresses over time and is so much safer for the patients. So a little video here, again, not advertising for Atrocure. I just use that company because they only do atrial fibrillation. So just a cartoon of how that works. It's flexible, so it can go through a small port. It can be reticulated in multiple areas. And that's important because everyone's left atrial appendage doesn't come off the same way. It's angled different ways. And I then just grab it with a pickup and then apply the clip. Look under echo and get a picture of what that looks like. And once I'm done, then just take the clip off. And this is what you're left with. You can see the endocardial view where there's no longer a lumen. So this has just revolutionized my discussion with patients and the people that I would be, willing to do because of the operative risks are so much better. This is what it looks like in an explanted heart in animal studies and confirmation CT scan. Of course, that's always there on the chest X-ray, and so there's always this thing showing up. So I'm just going to skip by this because this is a video of the procedure, but we're running a little slow on time. This is what the patient's incisions look like. Small incision, here's the nipple, here's the axilla, small incision here, and one for the chest tube. This is one of the first patients I did at St. Mark's back in 2005. So briefly, 3 quick studies as we finish up that have all been published in peer-reviewed journals on patients. None of them have hundreds or thousands of patients, but we're getting there. So 21 patients, 1-year follow-up, and again, these are freedom from Afib by very vigorous monitoring, not phone records like some of the other studies have been. And freedom from Afib is defined as no Afib off of antiarrhythmic therapy. 75% cure in all patients, 87.5 in paroxysmal, that first. No deaths, no pacers, no strokes. 2 patients did have flutter, and sometimes that can be a problem in the right heart. We don't do anything to the right heart. Another study, of course, Journal of Interventional Cardiology, 83 patients, 21 of those had previous catheter ablations, 82% cure. In the chronic category, however, it drops off, and this is before that more complete burn set that I showed you on the back of the heart. And excellent follow-up. However, it is invasive surgery, and there was 1 death in this series from bleeding. And then the last one, 22 patients, 1-year follow-up, 3.2-day hospital stay, 91% free from Afib, off of antiarrhythmics, again by vigorous monitoring, 91% of the patients off of Coumadin, again corresponding with freedom from Afib, no deaths. So I'm just going to zip through these. So the results, these are the 170 patients we've done at St. Mark's and Ogden Regional Hospital, their genders, their categories in terms of paroxysmal, persistent, and chronic, age range 34 to 91, operating room time, and these are our cure rates with all comers. So the last thing I wanted to just talk about as we finish up is something that's coming down the pipeline. It's already there at St. Mark's and hopefully coming to Ogden Regional, is the hybrid approach, or called the DEEP, dual endocardial and epicardial, where I do the minimally invasive approach while the electrophysiologist does wire catheter ablations from the inside to create all the lesion sets that are done in a complete Coxamaze 4, but without the sternotomy. And of course, this has obvious benefits for all those millions of patients with chronic Afib and benefit from both techniques rather than, one or the other and both of us having a certain percentage of failure rate. Started at St. Mark's, Cumming Ogden Regional, and we'll be the only centers to offer the deep approach in the region. And that's all I have. Any questions? Yes. When was her operation? 2003. Great. Great. I've paid for her to come and sit in the back and do that. Yes, sir. Well, so the answer is no. The earlier you treat it, the better. However, the caveat is to make sure other causes of atrial fibrillation are not there before we go do an invasive procedure. So I would say no, not too early, as long as we've ruled out such things as thyroid, such things as valvular heart disease and coronary disease. Once those things are ruled out, then no. I think the earlier you treat it, the more likely you are to be lifetime free from medications and the stroke risk. Yes, sir. Yeah, I think it's a point well taken. I just refer you back to the Affirm trial, data. 30% major complication rate at 5 years in all comers, maximal medical treatment, both rhythm and rate control, anticoagulation, bleeding, death, and stroke. I think the complication rate, if you're a good candidate for something else, is too high to be treated medically. That's my personal opinion. This pendulum is certainly swinging that way, all around the world actually. But it's again getting those 20 million Americans that are visiting their cardiologist every month or their primary care physician for an INR and saying, I feel pretty good, to say, be more aggressive to deal with the long-term complications rather than saying, I feel good today. Yes, sir.
So how are you deciding whether to do a catheter-based ablation versus one of these minimally invasive procedures that you're talking about?
Yeah, so I think in the paroxysmal category, many of the patients that come to me have had a previous catheter ablation attempt or two and still have atrial fibrillation, so they're referred by electrophysiologists. Some patients simply, if you think about a catheter ablation, extremely effective after 2 ablations in the paroxysmal category. However, the left atrial appendage is always there. That it's never gone. And so many patients say, well, now wait a minute. So I occasionally go in and out of Afib. It's not too bad. I tolerate it. But no one ever takes them off their Coumadin because the stroke risk is still there. So some of it's a patient preference and also referring physician if they have reasons not to be they can't be anticoagulated. So there's kind of a working relationship with the referring doctor.
So after this procedure, they don't need to be on Coumadin if you take out their appendage?
That's correct. Yes. Yeah, so I try to steer with this new approach, dual endocardial epicardial. We will be more aggressive about treating chronic patients with the less invasive, but I try to steer them towards an open maze in that chronic category because the results really from all the studies are about 50 to 60% cure in that chronic category. So the longest, I've done people with 10 or 15 years who've just refused to have an open maze. I want to try this first, and then I'll go to that if it doesn't work. So that's been done, but that's not my general approach. Yes, sir. I'm sorry, I didn't understand the first part of your question. Okay, so transvascular, with the open approach. It's more invasive, but you can do many more ablation lines and ultimately remove the left atrial appendage. With the transvascular approach, it's all inside. Of course, I showed you those nerves that I burn on the outside of the heart. I showed you the ligament of Marshall on the outside of the heart, the left atrial appendage. So there are pros and cons. We have to weigh that with the operative risk for the patient. Yes, sir. Yeah. Well, there have been several devices out there that have not come through. There have been big complication rates. Yes, sir. Yeah, so if the patient's CHAD score, which is a measure of their risk factor for stroke, is a certain number, then we do that. And many patients over 70, I'll just put the clip on. When I had to staple it before, I had to think about it more, but now with the clip, I'm more liberal. There's no real data to support that, except I know your typical 80-year-old that has Afib, we don't want to anticoagulate, fall risk, et cetera. So I do put a clip on it when I'm doing other things, just to hopefully diminish their stroke risk. Yes, ma'am. No problems at all. It was studied for years and years in animals. Of course, it was then studied in Europe, and it basically has this cloth that grows into the tissue of the left atrial appendage. It doesn't erode. So far, it's looking really good. Okay, thank you very much.